Good morning, everyone. How are you this morning? Great. So today we are going to discuss about diabetic emergencies. But before we get into that, I just have this statement that glucose test is not an investigation. It's part of the vital signs like temperature. It should be accessed by all. Why should someone come to hospital several times and no one knows their blood sugar level? So you don't wait for the doctor to say, do glucometer, do glucose test. It's a vital sign. The same you do temperature, you don't wait to be told that do temperature, do BP. Glucometer, glucose test is a vital sign. So that's what I just wanted to start with. So as an introduction or an overview, I think we are all familiar with diabetes. We all know what diabetes is. So I'll just ask some few questions so that it's interactive. May someone define diabetes for us?
Diabetes is a condition whereby the breakdown and the utilization of glucose is not proper. Maybe because of some diseases of the pancreas.
Okay, that's great. That's a very simple definition, right? So diabetes is a chronic metabolic disease characterized by high levels of blood sugar, and it may result from either insulin deficiency or insulin resistance. So it means something is wrong with the pancreas, like what Metron has said. What is the prevalence of diabetes? Anyone to try? How common is diabetes? What do you think is the prevalence of diabetes worldwide, or in Zimbabwe, or in Africa? How common is diabetes? It's very common. Yes, can we put some quantities? All right, how many people are in the world? World population. This is general knowledge, right? This is no longer medical.
8.06 billion.
8.06 billion. So
the last census was done in 2020.
Yes. So if we are 8 billion, know that 10% of that number are people living with diabetes, right? Which means maybe about 800 million people are living with diabetes, right? 10%. So 1 in 10 people are diabetic. It may be that someone does not know it, but 1 in 10 people as a world prevalence, 1 in 10 people are diabetic, right? So it means it's very common. It's a very common condition. So we really need to know about it because we meet it every day at the clinic, right? Types of diabetes. Let's list 5. Or N, just list 1. Types of diabetes. This is just an overview so that we understand the topic you are talking about. It's not even part of the presentation. What are the types of diabetes? Type 1, yes. Yes, good. Hey, what else? Juvenile, yes, that's type 1.
Insulin-dependent diabetes mellitus.
Insulin-dependent diabetes mellitus. That's type 1 again. It's another name for type 1. Yes?
Gestational diabetes.
Yes, gestational diabetes, the one in pregnancy. What else? So we have listed 3 so far. 2 left. There are many, but
Pre-diabetes Pre-diabetes.
Okay, pre-diabetes, that's good, yes. Pre-diabetes. Then we have latent autoimmune diabetes of the adults, LADA. Then we have maturity onset diabetes of the young, MODY. Then we have type 5 diabetes, which is a diabetes due to malnutrition. Malnutrition can actually lead to diabetes. So children who are malnourished during when they are young, they might end up having type 5 diabetes. So these are the most common types of diabetes we have. What are the risk factors of diabetes? Risk factors. What predisposes you to diabetes? Yes?
Family history of diabetes.
Family history of diabetes. Yes, yes, that's very correct.
Age and obesity.
Age and obesity. What is obesity? What is obesity? Overweight. How do we define it? Yes, it's overweight. How do we define overweight? What's the body mass index? The cutoff? Those who do vitals, you do BMI. Their BMI is this. You have to be able to interpret it. Yes, so what's the limit for us to say someone is overweight? What's the upper limit? Or what's the normal BMI? Normal body mass index? Okay, it's 18.5 to 24 or to 24.9. So anything 25 and above, 25 to 30 is, to less than 30 is overweight. More than 30, 30 to 34, class 1 obesity. Then 35 to 40, class 2, then 40, morbid obesity. So obesity can also be classified. Then what are the risk factors? Sedentary lifestyle. People are no longer active these days, so that's why diabetes is prevalent. Diet, the diet we are eating these days, it's also predisposing us to diabetes. What else?
Pancreatic damage.
Pancreatic damage, for example, due to alcoholism, etc. Whatever predisposes you to pancreatic damage will cause diabetes, right? So this was just an overview of diabetes. And diabetes causes many complications, including the eyes, the kidneys, the heart, the blood vessels. So those are the complications of diabetes. But today we are not discussing about that. So then I have a case which we want us to discuss briefly before we move into the specific diabetic emergencies. So this is a case, sorry, of a 71-year-old female patient who last visited to a healthcare facility 2 months ago. BP was checked, temperature was checked, but no glucometer was done. Presented with a one-day history of not being her usual self. That's what the presentation was like. Because on presentation, we say what the patient or what the relatives say, that she's just not herself, right? So this patient is not verbalized well, so because of the dementia. So no one really knows what's wrong with this patient, right? The systemic review, there was no cough, no diarrhea, no vomiting, no shortness of breath. Nothing really you can pinpoint to say this patient is sick because of this. Then on examination, BP slightly elevated, 145 or 90, SpO 291, temperature is normal. Then the random blood sugar, HI, right? That's high. The level of consciousness, because of a condition, it's difficult to do because someone with dementia, you cannot give instructions. So level of consciousness is always difficult to do in that case. So what would you do? But what I want to emphasize is this was not done. This was done as an investigation, not as a vital. It was done when the doctor instructed for us to take RBS, which means we could have missed and treated something else, not knowing. This patient does not communicate, does not tell you what they are feeling. They are just not their usual self. They are just down, right? We do our BP. BP is not that high. Saturation is okay. Temperature is okay. Then we could even send the patient home and say, maybe she has not eaten enough. Give her food. So what I want to emphasize is glucometer or a glucose test is not an investigation. We should not wait for doctors to instruct to do a glucometer. It has to be done to all patients. So, so what will you do? Someone with an RBS of which is just reading high. What does it even mean? High, HI.
Yeah, high means the glucometer is unrecordable.
Unrecordable. Above what value?
There is no specific figure there. Right.
So it means it has exceeded which values, roughly? What's the maximum? Yeah, around 30, 33. It's above 33 sometimes, yeah, because 32 can record. Sometimes you can see 33, 32, yeah. So it's above 33. We don't know where it is. It's just above 33 because the glucometers will not read. So what will you do in this case? This is just a discussion, no wrong answer. We will always correct each other. What will you do?
I think since for medication like insulin,
Mhm.
for the doctor to prescribe.
Okay.
But as nurses, since we are the one who have seen the patient first, maybe after having picked the RBS is high. The first step we do is we want to try to reduce the RBS. So we normally pick normal settings.
Yes, that's very correct. So fluids.
Fluids, right?
Yes, so give fluids, right? So start on fluids. Yes, of course, we'll do insulin therapy, etc. And also collect bloods for investigations for blood count, HbA1c, etc. Okay, so what are the diabetic emergencies? This case was not for discussion. It was just for deep discussion. It was just for us to see the type of patients we see, right? So, what are the diabetic emergencies? You know, let's list some diabetic emergencies because that's the topic for today. Any diabetic emergency, Metron?
Hypoglycemia.
Hypoglycemia, a very common diabetic emergency. What else? Hyperglycemia, yes, a very common diabetic emergency. What else? Like in this case, it was a hyperglycemia. Which other diabetic emergency?
Diabetic ketoacidosis.
Diabetic ketoacidosis. So that's again one of the commonest diabetic emergencies, which we are going to discuss more in detail because it's life-threatening. It's a very serious complication. So we are going to start. So like we mentioned, we have diabetic ketoacidosis. We have hyperglycemia, or we can say hyperosmolar hyperglycemic state, HHS, and hypoglycemia. So these are the most common diabetic emergencies. So we are going to start with DKA. I think we have all heard about DKA, diabetic ketoacidosis, right? Diabetic ketoacidosis. So this is a life-threatening complication that happens mostly in people with type 1, but can also happen in type 2 under certain circumstances, right? So, so diabetic ketoacidosis, from the name, diabetic ketoacidosis. So that's the definition. From the name, you can define what it is, right? Diabetic ketoacidosis, right? It means the patient is diabetic, right? So definitely there's hyperglycemia, then there's also ketosis, and there is acidemia, right? So that's the definition of diabetic ketoacidosis. So this is a life-threatening condition. This condition, where should it be managed? If you discover that someone is DKA, where should that patient be managed in a hospital setting? Where?
I think in a high care unit.
High care unit, HDU, right? So it means once we diagnose DKA, we should send to a hospital with HDU. If we do not have an HDU at the facility, we initiate treatment whilst preparing to send the patient for a HDU admission. You will see why it needs HDU, right? So it comes about as a result of insulin deficiency, and the body will break down fatty acids and releasing ketone bodies, resulting in most of the symptoms. So what happens is, if you do not have insulin, maybe let me start by what is insulin? What is insulin, or the role of insulin in the body? That's how we can understand what DKA is, if we understand the role of insulin. Or what is insulin? Insulin, Sekurbats. What do you understand? It's not like you have to say it as the textbook say. No, what do you understand by insulin? Insulin.
It is the component that is found in the body that breaks the sugars.
Exactly, right. So it is a hormone. Insulin is a hormone. It's found in the body. It is released by an organ called pancreas or chirwatata in Shona, right? So that chirwatata releases insulin. Insulin's function is to make sure that the glucose we eat, the carbohydrates we eat, are utilized. They are broken down and absorbed into the muscles, broken down and absorbed into the adipose tissue, broken down and absorbed into the liver, or being used for what it's supposed to be used for. Like for us to get energy, we need insulin to facilitate that. So if you do not have insulin, it means all the carbohydrates, all the glucose you are going to eat is going to accumulate in the blood, right? And yet it's not getting to where it is supposed to be. It's like having a full tank, but the fuel is not reaching to the whatever engine or whatever tank. So it can't get used, right, by the body, because something is wrong. What facilitates its use is not there. So that's why you see someone with diabetes, they are hungry, and yet their sugar is high. But they are feeling hungry. Some people starve them and say, no, don't eat because your sugar is high. But the sugar is not being used. It's just in the blood. So so insulin is very important. So it's important for the uptake of glucose into adipose tissue, muscle, and liver, and also it inhibits what we call lipolysis, right? That is the breakdown of fats, right? So when the body discovers, let's say you do not have insulin, so what the body does is to say, okay, but this person cannot die because there is no glucose is not reaching the cells. What do we do? So the body will start breaking down the fats. It starts breaking down the fats because the mechanism for breaking down the fats it does not need insulin to break down fats. Actually, insulin opposes the breaking down of fats. So what the body does, it uses the mechanisms it has to break down the fats so that they can be used for energy. So this happens to people who fast. So if you do a prolonged fast, let's say 3 days, 4 days, 7 days, 40 days without food, the body will start to break down. Actually, from day 3, the body starts to break down your fats to get energy. But in the process, it releases what is called ketone bodies. In the process of trying to help, there are products which are produced, which are called ketone bodies. So these ketone bodies have to be, if there is some insulin, they have to be wiped from the body. But because there is no insulin, the rate of production of ketone bodies becomes too high, and these ketone bodies causes problems. That's why we end up with diabetic ketoacidosis, right? But the body was trying to help, to make sure that the person is living by breaking down the fats. But this process becomes overwhelms and produces too many or too much ketone bodies, which the body cannot what? Cannot bear, and they can cause these other effects, which we are going to talk about. So when there is no insulin, this is what the body does. It breaks down fats. It also manufacture glucose on its own using a process, using the proteins we have. It creates some more glucose because it's sensing that we do not have enough glucose in the cells. So it will create more glucose, again worsening the situation. So it's like a cycle. So this diagram is trying to explain what happens. So there is insulin deficiency, which means there is decreased glucose uptake in this route, which leads to hyperglycemia. This one alone will lead to hyperglycemia. Then we go to the other route. So because the insulin deficiency, the body will break down proteins again. And when it breaks down proteins, there is what we call amino acids. There are a lot of amino acids in the body. Then the body again will use these amino acids to create glucose, because it's sensing that there is no glucose, and yet there is glucose. So worsening the situation, more glucose in the blood. Even if they do not eat, it will continue to increase, because the body will manufacture its own glucose, right? So that's number one. So we end up having too much glucose in the body. Then another route, there's no insulin, the body will break down fats, leading to free fatty acids and leading to ketogenesis, because when there are free fatty acids, those free fatty acids are converted into ketone bodies. Then these ketone bodies, when they are now too much, they will lead to acidosis. The blood become acidic. So we end up having diabetic ketoacidosis, right? So that's how it come about. So because of this, because of too much glucose will start to pass through urine, right? The kidneys will excrete this glucose. And if there is a high concentration, if the urine is concentrated, it will draw more water, so that it will lead to what is called osmotic diuresis. So they will produce a lot of urine because there is it's too much concentrated. So if there is osmotic diuresis, there is dehydration, right? It means the person is losing a lot of fluids. So this dehydration will now lead to this complication. That's why we said fluids. When someone comes, the treatment is more of fluids than even the insulin. Before even we start insulin, the first thing are fluids. Right, so pathophysiology, I think I have explained using the diagram. I think I've explained that again. So the ketone bodies are the ones which lead to acidosis. So what are the symptoms and signs of DKA? What are the symptoms and signs of DKA? Anyone? We can just read the symptoms. Nausea, vomiting, yes. Thirsty, then polyuria, passing a lot of urine, right? They can even pass maybe 3 liters in a short space of time. They will always be passing urine, right? Then abdominal pain, shortness of breath. So they will have this shortness of breath. So if you see a young patient, diabetic, having shortness of breath, think about diabetic ketoacidosis. Then the physical signs, tachycardia, dehydration, tachypnea, that's what we call casmal breathing. Then a fruity odor in the breath, that the ketotic breath, abdominal tenderness, lethargy. Sometimes it might lead to coma. Some actually come in coma. So what causes this? Usually it comes about in diabetic patients if they have an infection, if they have inadequate insulin administration, or any other complications, or if they are pregnant, they can easily get into DKA. So diagnosis, like the definition, DKA, diabetic ketoacidosis, though the patient is diabetic, definitely there is hyperglycemia, there is ketosis. We can do a urine dipstick. So that's another vital which we might need to have by bedside. It's a bedside investigation. It does not need the lab. So we should always have urine dipstick by bedside. At least it may not be a vital sign, but it's a bedside investigation. Like when the doctor comes, they can order, can you just do a dipstick? I think that's even in the public hospitals, that's what they do. Dipstick does not, you don't need lab to do urinalysis. It should be there. So we should also work towards that. So what's the management? So mainly we are just correcting what has happened. We want to correct the hyperglycemia. We want to correct the ketosis. We want to correct the acidosis and the other complications which come because of DKA, of the dehydration, etc. So that's our main goal of treatment. So how do we correct dehydration? How do we correct dehydration? IV fluids, right? So we have to give fluids. Also, we need to, since there is insulin deficiency, we have to give insulin. Then diabetic ketoacidosis also leads to electrolyte imbalance because of that polyuria, etc. So we need to correct the potassium, we need to correct bicarbonate. So these are the main things we need to focus on. So for fluids, we usually use normal saline for the first 4 hours, right? So how much fluid do you think a person with DKA needs to get in the first hour? In 1 hour, how much do they need to get? Just guess. How many liters do you think they need to get in 1 hour? In the first hour? 2 liters. Even up to 3 liters in 1 hour. Which means, right? Kana kuisa a wide book cannula ekuti inoita kana 10-15 minutes fluid richirana ratopera. So in the first hour, because the moment a patient comes in DKA, they already lost my fluids akawandisa. So we need to be on point, to be in keeping with the fluid loss. So in the first hour, you can actually, of course, there will be, you assess how much they have lost because they come also in different presentations. So 1 to 3 liters in the first hour. Then in the second hour, you give another liter. Then in the next 2 hours, you give another liter. So which means if we give 3 liters in the first hour, second hour, another liter, we are now at 4 liters in 2 hours. Then up to 4 hours, we can have 5 liters, right? Of normal saline, right? Then after that now, we can switch the fluids to half normal saline, which can run maybe 4 hourly, depending also on the assessment. Then we can switch to 5% dextrose if glucometer is less than 14, because we still need the insulin. So we don't stop the insulin early because we want it to clear the ketone bodies. So when the glucometer falls below 14, we switch to dextrose so that we maintain the glucometer at a certain, we also want to avoid hypoglycemia. Then insulin replacement, usually the best way is intravenous IV, right? Instead of subcut, which we do for other patients who are not in DKA. So we have to give it IV, best as an infusion. So we used to have infusion pumps. I don't know whether when the HDU was running, we used to have those infusion pumps. So it's better given as an infusion. But let's say there is no infusion, we can give hourly. Let's say maybe 5 international units every hour IV until the patient stabilizes. So that's basically insulin replacement. So potassium replacement, so which means potassium replacement, you can do it if the potassium is greater than 5.5, you don't give, but if it is low, that is less than 3.3, and right, you may actually withhold insulin, because insulin leads to hypokalemia as well. You may withhold insulin and infuse potassium at a higher rate, right? So which means you need to have U&Es available. So every 2 hours you are doing a U&E. So that's why I was saying this patient can be, is feasible to manage them in HDU, where you are doing U&E every 2 hours. So it means if you are in a casualty, you need to go to the lab every 2 hours, collect blood. So it's not feasible, right? So it needs high dependence unity. And also those acid blood gases, they need to be done hourly. Every hour you go to the lab, do a BG. So it needs an ICU and HDU where those facilities are easily available. Then, okay, you can also do bicarbonate replacement depending again on the values from the lab. Then how do we monitor? We monitor the mental status of the patient, vital signs. You monitor the insulin dose, the fluid and electrolyte administered, and urine output. You also do glucometers 1 to 2 hourly. Then electrolytes, you can also do them, like I said, electrolytes, you can do them sometimes every 2 hours and sometimes every 4 hours, depending on the severity of the condition. You also monitor BP, pulse respiration intake and output every 1 to 4 hours. So that's diabetic ketoacidosis. The other diabetic emergencies, like what we said, we have hyperglycemia or hyperosmolar hyperglycemic state, which happens mainly in adults. So these ones, again, the management is more or less the same. Fluids, insulin, and you monitor the electrolytes. That's more or less the same. So let's say you are in a combi, someone of vita hypo, what do you do? And they're in a uniform. People will look at you and say, exactly. Give them, yeah, so give them something chirichi, yeah, juice, sweet, sugar. So because people will look at you, say, these are, yeah, vanoshanda kuchipatara. Munadona. Saga, yeah. So that's hypoglycemia is quite straightforward, right? We just need to correct the sugars. If someone is in coma or that's when we eat. If they cannot eat, take orally. We give. If it's in the hospital setting, we now give intravenously. We can give 50% dextrose to correct the hypoglycemia and maybe maintain on 5%. So what are the symptoms of hypoglycemia? Hypoglycemia. If your sugar become low, too low, what are the symptoms? Confusion. Mm-hmm. Yes. Sweating. Mm-hmm. I think we have all had hypoglycemia at some point. When you are at the reception and it is so busy, you start to have confusion, right? It's hypoglycemia. Yes. And what are the symptoms?
Feeling faint.
Feeling faint, yes. Feeling faint. Sometimes?
Coma.
Coma, yes.
Hungry.
Hungry, yes. You feel a lot of. What else at the reception? Did you know better busy staring?
Feel shaky.
You feel shaky.
Blurry vision.
Blurry vision. Unataka kuona rima. Yes.
Headaches.
Headaches. Yeah, so people know about hypoglycemia. Yes, what else? Irritability. Irritable. Easily irritable. So we don't going to refer patient. So make sure the administration, matron is here. Just make sure that these guys don't go into hypo. Just give them a minute to go and eat something. Because otherwise you do many root causes. Because that's hypoglycemia. Right. So any questions?
Just wanted to check on the dosages for the fluids, for example. Is it across the board that we talk of the liters, or if it's a child, we reduce the volume?
Okay, of course, we do pay. These are for adults, adult children. Like what I've the doses I have alluded is for someone, for adults, right? So when they are children, we always calculate per kg body weight. Yes. So I've presented it as adults. Even saying 5 units international of insulin start, that's for an adult. So for children, we have a doses per kg body weight. Right. Yes.
The coach that opened the discussion was saying glucose test is not an investigation, right?
Yes.
So my question is, so we are going to take vitals, we are going to take glucose test for all patients.
Right, that's the ideal. Because why are you taking their BP? Are they hypertensive?
Okay.
Are they hypertensive? No.
So I think that should be communicated with.
Yes, so of course they need to be some logistics in terms of admin. That's supposed to be the way forward.
Those lines just walk in.
Of course, no, of course that one is separated. We are saying for someone who wants to consult, at least let us know their glucose test, like the way we know their BP, right? Because like I said, that case, that patient was going every month to collect their BP tablets, have their BP checked, have temperature checked, saturation, etc. So diagnosing someone with a high glucometer, it means we have missed it all this other time. So I think it's high time we change some of the practices, right? So yeah, that's my recommendation. Yes, of course, it needs to be discussed with those responsible for but but it should be accessed by all. Because when someone comes to the clinic, atouya vana vauye kuclinic zvekumhanya, saka at least totombatira ipapo toitwa glucometer as well, ongoziva kuti sugar yake iri papi. Remember we said 1 in 10 people, 10% are diabetic, right? So it means we will save a lot of lives by diagnosing them early. No matter what, whether it's a child or what. Let's just make it a part of the vital sign. Right? In other countries, when you walk into a casualty, even my x-rays, my vital, x-ray, MRI scan, I'm just saying, for example, that they can actually go beyond doing many other investigations. But of course, in our setting, because of resource limitation, we just do the basics. But at least glucometer, let's fight that it's part of the vitals. Thank you very much. Any other question? Thank you.